عليكم السلام ورحمة الله.
واضح البرزنتيشن الباوربوينت عندكم؟
واضح لكل.
تمام إن شاء الله. اليوم إن شاء الله يكون our last lecture in this course with pediatric cardiology, and we talked in the last weeks about the investigation of patients suspected of congenital heart disease or heart failure, with cyanotic congenital heart disease. Talk about VSD, PDA, coarctation of aorta, ASD, and then we talk about the cyanotic congenital heart disease, including the etiology of fallot and transposition of the great arteries. Today we'll talk about the heart failure. What are the definition of a patient with heart failure? It is a condition in which a problem with the structure or function of the heart impairs its ability to supply sufficient blood flow to meet the body need. There is many classification for patient with heart failure. One of them is this classification in dividing the patient with heart failure into 4 stages. Stage A, in which the patient was asymptomatic with no heart damage but have a risk factor for heart failure. So this patient, we should start treatment with them before the patient becomes symptomatic. Like sometimes large VSD, we see the patient is asymptomatic, discovered accidentally, but when we see the heart, we see that there is overload of the heart, and this patient will definitely will develop heart failure in the future with large VSD. So we start him on treatment in this stage. Stage B, the patient will be mildly tachypneic or diaphoresis with feeding, sweating, we see him, and dyspneic on exertion. Stage C will be marked tachypnea or diaphoresis with feeding, growth failure, marked dyspnea also on exertion. While stage D will be end stage heart failure, tachypnea, retraction, and the grunting, which means a severe dyspneic patient, and also with diaphoresis sweating at rest. Now we'll come after talking about the definition, classification. What about the causes of heart failure? The causes of heart failure are different according to the age group of the patient. They develop in the fetal period, in the before the delivery, or may develop heart failure during the neonatal period, or in the adolescence, or in the toddler age group. Each age group will have different causes. For example, in the neonatal period, the patient may develop heart failure due to patient may have DTGA. We talked about it in the last lecture. And critical pulmonary stenosis, severe pulmonary stenosis. This will end with pump failure and heart failure. Single ventricle, also this is isolated entity, and we didn't enter into its details, but have need more than one lecture to talk about it. It have different types and different entities. There is about 52 types of single ventricle associated with different anomalies. But here, for your age. I want you to know a single ventricle may develop uh, heart failure in the neonatal period, one of its types. Also, critical aortic and aortic stenosis and mitral valve disease may develop heart failure in the neonatal period. Tetralogy of Fallot, and as we said, which type of tetralogy of Fallot? Usually the pink type, which associated with mild pulmonary stenosis. This the patient will act as large VSD, and they are liable for development of heart failure. And last type will be the Epstein anomaly of the tricuspid valve, and this is also a rare anomaly, one of the congenital heart disease of the heart, which is rare, and the patient here will develop malformation of the tricuspid valve and deformed, and plus apical displacement of the tricuspid valve uh, will be more near the apex, and so there will be semi-arterialization of the right ventricle. The the right atrium will be very large, while the, the the right atrium will be very large, while the right ventricle will be small because of the apical displacement of the tricuspid valve. What about the causes of heart failure in the older children, including secondary to acquired causes? May include the rheumatic fever, or if you heard about it and know the causes of it and treatment. We don't have enough time to discuss all of the details of a patient with rheumatic fever. Uh, Subacute bacterial endocarditis, also these patients liable for development of heart failure. Also, this subject not discussed in our curriculum because of limited time. So these subjects, I think you took it in the medicine, so should have good background about these two subjects. And third cause will be cardiac arrhythmia, and this subject also you should have a good background, and we will have a seminar. We'll take it in, inshallah, on the sixth grade. We'll discuss it in details on what are the common causes of arrhythmia in pediatric age group. So this patient are also liable for the development of heart failure. Example of it like SVT, which is the most common arrhythmia in pediatric age group, and those patients have developed arrhythmia for long duration, more than 24 hours. They are liable for development of heart failure. So it is one of the emergency. The patient have developed uh, cardiac arrhythmia. We tell the patient, the relative of the patient or the child, you should treat it as soon as possible, because if still for long duration, the patient will end with heart failure. Other causes including anemia, high blood pressure, severe hemorrhage, cardiomyopathy, and it's all three types. As you know, we have three types of um, cardiomyopathy, including dilated cardiomyopathy, which is most common, and also we have hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. Uh, Also, post-operative complication, cardiac surgery may develop heart failure. While cardiomyopathy is common as at this age, usually um, may have many causes. Maybe drugs cause it, maybe infection, or maybe idiopathic, and the infectious causes usually viral. And the viral infection, as we know, is common in winter season, and the scenario of it as the patient usually come with history of flu-like illness like influenza or coughing or mild fever or tachypnea or any of the crisis symptoms, and then after 1 to 2 weeks they develop severe shortness of breath, difficulty in feeding, tachypnea, tachycardia, and we do echo if you get a high index of suspicion of it, and by echo we see the patient will develop myocarditis and ended with dilated cardiomyopathy. Uh, we see many cases of these, and it's usually one of the disastrous cases because the child usually previously healthy, just a simple influenza, sometimes very, very mild symptoms, and this virus will attack the heart and the patient and causes myocarditis, and the patient will end with severe heart failure, congested, and very low ejection fraction. Sometimes do not get above 20%. So, as you know, all of you, the cardiac output depending on the heart rate multiplied by the stroke volume, and this from the physiology, as if you remember, the stroke volume depending on the afterload, on the preload, and also on the contractility. So all of our drugs and treatment will depend on these four factors, including the heart rate, drugs like beta blockers, drugs acting on the afterload, like the ACE inhibitors, the preload, uh, like diuretics, and the drugs that act on the contractility, like digoxin, dopamine, and butyramine. As we said previously, the heart rate can compromise the cardiac output, like tachyarrhythmia. This will shorten the diastolic time interval for ventricular filling and with heart failure. Also, anemia or hypoxia can also lead to decrease the systemic auto transport, and this compensatory mechanism are inadequate will decrease the delivery of substrate to the tissue. And sometimes the heart failure can occur in spite of the normal cardiac output or even more than normal, secondary to increase to anemia or increase auto demand like in cases of hyperthyroidism. What about the clinical manifestation of patient with heart failure? Usually in infancy, it will develop feeding difficulty or interrupted feeding, and شوف المرة تجيك تلقى لك دكتور رضعات مالته تطول. ممكن عادة احنا نعرف الفيدنج رقمين مثلا أو في اليونيت أو 2 months of age، مفروض خلال 5 دقايق 10 دقايق يكون كاملة رضعة. الأم تجيك تقول لك دكتور ربع تمارين خلال ساعة، ساعة وربع، يلا يخلص له رقم أو رقمين، في كل ساعة يقطع ربعة يرتاح وبعدين يرجع ياخد. فأنت المفروض تخلي بالك الهارت فيلر. Usually the patient is failing to thrive, malnourished. شوفهم دائما، شوفهم back from the other children or with their age. Other at 4 months usually their weight should be 4 to 6 kg, and we see them their age still their weight still 3 kg, 3.5. So for their weight far below the first centile, and this is one of the problems for a patient of congenital heart disease and patient with heart failure. And our goal of treatment here is correction of this failing to thrive. So when you see the patient with at the follow-up, we see him with thriving well, mean the patient we are in the correct pathway and we're giving him the correct treatment. But when we see the patient is not thriving and far away from his colleagues at the same age, so we should intervene, either increasing the dose of the treatment or if we have a patient for cough or surgery to correct his problem. Uh, Also, patient will be tachypnic and with respiratory distress. We will see that costal, subcostal restriction, and even in severe dyspnea will develop the grunting. And as we said previously, diaphoresis, excessive sweating, usually on exertion, on feeding, on crying, and when the stage, even at rest state, will be with excessive diaphoresis. Tachycardia, patient will develop tachycardia according to the age, usually the neonate, the normal heart rate, as we know, from 120 to 160, even to 180. But when the patient with heart failure will develop more tachycardia, even 200, 200, 190. So increasing the heart rate, weak crying, pneumonitis due to pulmonary congestion, especially in the right and the middle lower lobes of the lungs, and hepatic congestion, and also these patients will develop hepatomegaly. Cardiomegaly, we see it by chest X-ray also, and gallobridim, the patient will develop third and fourth heart sound in addition to the first and second heart sound. So this is distinctive sound when you hear the gallobridim, the fourth heart sound. We should think of heart failure. And also clinical assessment of jugular venous pressure in these patients is usually difficult in the infancy because of the short neck and difficult of patient to be relaxed. You see the infant usually neck مالتهم كلش واضحة، ما تقدر تشوفها وما تقدر تفحصها، لذلك احنا ما نركز عليه حتى بالاكزامينيشن. حكينا بالرابع أو إن شاء الله بالسادس. JVP is not part of the clinical examination in pediatric age group عكس adult patient. Also, these patients may develop edema, which is maybe generalized and usually involving the eyelids, the sacrum, and less often the legs and the feet. In the physical examination, we auscultate the heart and we may find the, in addition to the galopin, we may find a murmur, and this murmur may lead us to the primary cause of heart failure. If we hear a hollow systolic murmur, for example, in the tricuspid area for intercostal space, we should think of VSD, and maybe VSD is the cause of patient with heart failure. This is another score for uh, division of a patient or of infants with congestive heart failure divided into mild, moderate to severe, and each sign or symptom is giving a degree from 0 to 1 to 2, and this will divide the severity of a patient with heart failure into mild or moderate to severe, including the breathing, how is the breathing of a patient, is he tachypnic or not, difficulty, interrupted feeding, vomiting, sweating, irritability, poor activity, and lastly, the edema. What about the clinical manifestation in older children? Means the patient will develop shortness of breath also, also will be tachycardia, tachypnea, and hypermegaly. Also, due to bronchial congestion, may develop wheeze, we call it cardiac asthma, and lastly, peripheral edema. So, for sign and symptom, we should keep it in mind whether the patient is infant or all children. We have too large and too rapid sign. Too rapid اللي هي including tachycardia, tachypnea, or too large اللي هي cardiomegaly and hepatomegaly. These are important. If you think of case of heart failure, you should look for these four signs. What about the diagnosis of patient suspected of heart failure? This will do a chest X-ray and usually assessing the size of the heart. And many patients refer to us suspected of heart failure by doing X-ray, which is a simple, easy investigation and available 24 hours by your hand in the emergency room. If you suspect a patient with heart failure, you can send him for chest X-ray. And if you see a cardiomegaly, so you will refer him and set an appointment for him for echo study to exclude the presence of heart failure. Also ECG, and we will have a session in the 6th grade, inshallah. We'll talk about the cardiac enlargement and arrhythmia, the patient with how to read it in the ECG in the patient with heart failure and congenital heart disease. Further investigation will be echocardiography, and here we will know about which is the type of congenital heart disease that causing, but VSD, ASD, tetralogy of fallot, transposition of a great artery, any congenital anomaly will be seen by what about we see the chambers, and also we see the contractility of the heart and the ejection fraction of the heart muscle. طبعا with the echo study will be Doppler study to assess the cardiac output and to see if there is any abnormality in the flow, in the arch, in the valve. Previously, كانت two machines and أبي ماشين موجودة مستشفى رشيد مثلا عندهم دوبلر، مستشفى ابن البيطار عندهم الإيكو كارديوغرافي. فإذا شفت البعض مثلا عندك ستينوسيس ادز دوبلر غير مستشفى حالة حتى تشوف الفلو والدوبلر. هسه ناو نيو ماشين هي كلها ممكن بيها تشوف الإيكو، ممكن تشوف الدوبلر by the same machine, and you assess the flow and cardiac output of the heart. طبعا ممكن انه all these investigation we do chest x-ray, ECG, echocardiography and Doppler study, and we do not reach the final diagnosis, and we see the patient is still in failure, and so we should do cardiac catheterization and coronary angiography. Uh, this is the last step, and may reach the final diagnosis by doing this procedure under GA. And we see many cases like anomalies in the coronaries. We know we do not enter into details of it. We have many anomalies on the coronaries that may cause ischemia and heart failure in the infancy and in the early age group. So, and we do not know the cause of this uh, by chest X-ray or ECG or echo, and we reach the final diagnosis by doing the coronary angio for the patient, and we see the anomaly and compression of the coronary, and this may cause the ischemia and heart failure in these infant or children. Also, we have another investigation, which is MRI of the patient, but is still not available in our country for diagnosis of special causes of heart failure. And we have biochemical study, including beta natriuretic peptide, and this will be increasing cases of heart failure and cardiomyopathy, and in cases of volume overload or left-right shunt, like VSD. Some practical points, including any patient with heart rate up to 120, usually should make you suspicious of SVT. And as we say, this is one of the cardiac emergency and should be treated immediately by drug therapy or putting a ice on the face of the infant, or if the old patient, old age group, adolescent, doing the Valsalva maneuver. If of no benefit, we give him a drug like adenosine or caldaron or the drug scene according to the drug available in your hospital. And if all of these don't succeed to stop the arrhythmia, you can give him the synchronized DC shock for correction of the arrhythmia. Patient tachypnec, as we know, the patient usually considered tachypnec if the respiratory rate is more than 60 in the neonatal period, while if it is above 50, we consider him tachypnec if the patient age between 1 month and 12 months of age during the infancy, while above 1 year of age, if the respiratory rate is more than 40, this will consider him tachypnea. CT ratio, as we say, is important. If you suspect a patient with heart failure, you send him for chest X-ray, and you find the cardiomegaly, you should send the patient for echocardiography to exclude heart failure. And usually the cardiothoracic ratio more than 60% in the newborn or more than 55% in the older infant. This is a sign of cardiomegaly. And maybe there is a false positive result due to the patient cannot take a full deep breath. You know, in the adult, we told we tell the patient to take a deep breath and take the X-ray. In the infancy or small children cannot do this maneuver, so the heart will be larger in size than will appear large in size, while when we do the echo or when we take a full respiratory film, the heart will be normal. So it's false positive cardiomegaly. What about the treatment? Usually we treat the cause. If the possible cause can be treated, like large VSD, we do surgery with the patient so the failure will improve. Um, but if we cannot do the patient for whatever the reason, so we can give him medical treatment and do supportive measures. And these supportive measures including the bed rest, which is usually rarely needed, but sometimes we advise them uh, to put the infant or child to sleep in semi-upright position. The diet is important. Usually, as we say, most of the patients will develop failure to thrive. So we try to increase the calorie intake of the patient by increasing the number of calories per ounce up to 24 kilocalories per ounce. As you know, the normal formula available on the market uh, usually contain 20 kilocalories per ounce. So we have a special formula for patients low birth rate or failing to thrive. This will increase the kilocalorie up to 24 kilocalories per ounce. So to increase the weight gain. Uh, but we cannot increase the calorie more than that because of the patient may develop diarrhea, and these formula provide too large solute load for compromised kidney. Also, we can use a supplementary breastfeeding, this including آه، احنا نجيب يعني البلك of the mother، عادة نسميها الملاطة، ونسحبها ونطير التشايلد حتى نقلل الورك لود على الانفنت أو التشايلد، أو حتى ما يصير عنده heavy exertion. In case of weak sucking can use a nasogastric tube. لذلك مرات حتى تشوفون احنا يجيكم مرضى الطوارئ باكر عقبه تشوفون حاطينهم على ام جي تيوب، مع العلم هو جود ساكينج. ممكن يكون احنا حتى نقلل الاكزيرشن على الانفنت او التشايلد، لذلك نخليهم ان جي تيوب ونحاول ندفع لهم اكثر كميه يقدر يتحملها وكونتوليريتد to increase his thrive or increase the calories the patient can take it. لذلك كل أسبوعين أو 10 أيام نبدلها بالطوارئ حتى ما يصير انفكشن، ونخليه على ان جي تيوب وندفع له الفيدنج من خلال الان جي تيوب. طبعا use of low sodium formula not recommended because these are usually poorly tolerated and exacerbated diuretic induced hyponatremia and دخلنا بمشاكل electrolyte disturbance. لذلك فإحنا المفروض patient cannot not give him a low sodium formula. What about the drugs that can give him to the patient with heart failure, these including the nootropic drugs, uh, these acting on the contractility, as we say in the beginning of the lecture, including digoxin, and we have also dopamine, the butamine, epinephrine, and usually only drug that is given in the outpatient is the digoxin, and the doses of it is available in your textbook, and maybe ask about it. So you should go to your text and write the exact doses, some of it, because the pediatrician or some senior may ask about how to calculate the exact dose of digoxin. Also, the afterload reducers, including the capotin and enalapril, and this is available in the market and in the hospital. We can use it in the outpatient treatment. And the C will be the diuretics like furosemide and thiazide. Furosemide is most potent diuretic and can be used in patients with heart failure. And lastly will be the beta blocker, carvedilol, also show improve in the morbidity and mortality of patients with heart failure. So any patient with heart failure, if you see it in the next year, inshallah, in the sixth ward, you see that we put him on anti-failure measure for anti-failure measure, including the digoxin, the capotin, and the diuretic furosemide. This is the full anti-failure measure for patients with heart failure, plus minus L13 locally or carvedilol. I think this is the last slide. We continue, and this is will be the last lecture in pediatric cardiology. We finished our lecture. If anyone have a question, can ask.
Doctor, for carvedilol, can we use it in acute heart failure?
Yes, in acute or chronic heart failure. طبعا there is controversy in its use, but there is many new studies show good improvement in the morbidity and in the hospital stays and in the days or mortality of the patient with heart failure. So we started in the patient with acute myocarditis and heart failure. If you see such a patient in the hospital, you see him, we put him on carvedilol. Previously, nowadays, they say it is contraindicated in its usage in cases of chronic and acute heart failure. nowadays شوف الستاديز كلها اتغيرت وشافوا good improvement of the patient of heart failure. واضح؟
دكتور احنا بالميديسن كان يقولوا لنا بالكرونيك عادي نقدر نستخدمه، بس بالاكيوت كانوا لا يقولون ما نقدر نستخدمه.
والله هي الدراسات قلت لك يعني متغيرة، بس احنا سابقا حتى بالاكيوت والكرونيك كانت كونترا انديكيتد. انتم ما لحقتوا على هذا الايرا زين. فهسه حاليا لا، هسه احنا بالنسبه لنا قاعد نستخدمه بالاكيوت والكرونيك، وهو ماني ستاديز يشوف امبروفمنت، واكو ستاديز لحد الان يقول لا of no benefit and not use it. فبدنا نشوف احنا امبروفمنت ويل، هل هو زين ما نعرف زين التايب، هل هو زين شنو تغير الأذر دراجز، بس النيو ستاديز اللي تجي كلها هسه تقرا تشوف with it goes with it and they start to use it. طبعا احنا عادة تبدي بالميديسن يوز وبعدين يوصلون للبيدياتريك. احنا الأول يوز دراج هسه احنا بالبيدياتريك ايج جروب هو الكاربيدولول، بعدنا ما مستخدمين لا البيزابولول ولا البيتابولول. بس كيوزج اكسبيرينس والله جود ريسبونس ده يصير عندنا بالاكيوت والكرونيك. طبعا في الدايليتد كارديومايوباثي تنقيهم نيد ادمشن، واول ما تستخدمهم هم دول الفول انتي فيلر والفيفوت وهي البيتا بلوكر، فهذول بعدهم بالاكيوت ستيج صحيح، اول اسبوع او اسبوعين عادة تخليهم in the hospital هذول الشوك ستيت. ف الريزلت مالته ولا بروميسنج ماشي. وشافوا هم يعني البيتا بلوكر بيشوفوه هو الكورنر ستون بالكارديولوجي. هسه شوف كله يدخل بكل شيء، يدخل هو البيتا بلوكر، وصحيح.
تمام دكتور. زين دكتور، هم كنا بالاكيوت هارت فيلر يقولون مثلا ممكن نستخدم سيداتيف حتى مورفين مثلا. بالبيدياتريك هم هيك شيء يعني واحد يقدر له لا؟
والله ما مستخدمين يعني بيشنت اريتابل قصدهم وهذا، بس احنا بالمورفين ما مذكورة وما مستخدمين وما شايف فيه يعني. تشوفه اريتابل بالاولدر ايج جروب، بس هذا التشايلد يعني شو راح تعرف؟ زين هاي شغلات انت شوية سبجكتيف. زين ان بين او زين هم مو بس المورفين يطول حتى من المايلد سيداتيف، مو الاكيوبان والهذا شوفه من stretching of the muscle والاسكيميا والهاي مو يستخدمون هواي سيداتيف بيها.
ليه دكتور؟ بس هو شنو هم ليش كانوا يقولون المورفين؟ لانه على اساس انه المورفين يعني يسوي فينو دايليشن، يعني فقالوا يجوز مثلا انه يقلل البريلود شويه، فهمات يساعد بالتريتمنت مال هارت فيلر.
ما عندنا هيك انديكيشن بصراحة بالبيدياتريك ايج جروب. ما قاري اي مصدر وما مستخدمين سابقا، وفقط الانديكيشن الوحيد به هو اللي قلت الفينو دايليتيشن، ويستخدم بالتيتولوجي او فالوت بالتيتسبيرز. زين بالهارت فيلر لا ما سامع ولا قاري بيه بالبيدياتريك ايج جروب. يجوز بالمستقبل، بس يعني هو انت شايف المورفين تدي البيشنت بعد يعني مو مثل الادلت يروح ينام وانت ما تعرف بعد يضيع عليك الاول والتالي، مو صحيح؟
اي دكتور.
ايه يعني صعبة، وهو تشايلد اصلا ما تعرف شنو القضية من عنده، فشوية يعني الاورينتيشن عندك كلها راح تضيع على البيشنت مالتك. فما اعتقد يعني بنفيشال بالبيدياتريك مو مثل الادلت. الادلت كان توليريت مرات حتى تعطي مورفين ويبقى صاحي والامور ماشية عالبة، خاصة إن هم هذول ماني دراجز ماخذ وزين تضطر تزيد للدوز. بس البيدياتريك من تعطيه المورفين هو بعده جسمه أصلا ما متعود على دراجز، وهذا مثلا تشوفه مثلا يروح زين وبعد ما تعرف شنو هل هو الافكت مال المورفين، هل هو الافكت مال الفيلا، مو صحيح؟ تخبط الامور عليه.
زين دكتور، وهاي مثلا السيتنج بوزيشن والاكسجين ثيرابي اللي هم ما كنا نستخدمهم بالادلت، هم بالبيدياتريك موجوده؟
وموجودة قلت لك موجودة بالكتابة بصراحة، والأكسجين أيضا موجود زين، بس ما مطبقيها يعني. يمكن هسه تروح دورتها تشوفها مذكورة بالكتب وإحنا نحكيها وحكيناها، بس بصراحة كتطبيق عملي بال بالوورد ما راح تشوفها. مو مثل الأولدر يجيكوا الأولدر يجيكوا بشوفهم كلهم هم يجيك يقول لك أنا حاطة مخدتين وثلاثة، مو من هنا
اي.
مو
اي.
صحيحة، ونصعد له احنا الثدي بحيث انه يكون هذا سيمي سيتنج بوزيشن. بس بالبيدياتريك ايج جروب ما هو طبق، ما اعرف ليش عندنا ولا اوتسايد. زين شوية ديفيكالت انت هذا اليونت يعني. هو هل قد شلون راح تخليه يعني سيمي سيتنج صعبة، مو صحيح؟
اي.
شوية ديفيكالت انت ثيوري تحكيه صحيح، بس من تطبقه بالعمل شو تقول؟ حط المخدة هو اصلا ما المخدة هي اطول من عدة مرتين، مو شوية ديفيكالت. زين حتى بالانكوبيتر هم نفس الشيء، ما عندك انت هاي الستاند مال الثدية وتقدر ترفع يعني. على العموم تقدر تسويها، بس شوية practically difficult to be done. واضح؟
دكتور، بداية المحاضرة همات كان الفيرال مايوكاردايتس، يعني إذا patient viral myocarditis وصار heart failure هو المانجمنت مالته نفس المانجمنت مال اي هارت فيلر مو؟
تمام the same يجوك ذولا typical presentation viral illness before 10 days to 2 weeks, then after 2 weeks يجيك with severe heart failure, decreased feeding, tachycardia, galopin, and we do echo, we see very low ejection fraction, usually below 30, severe compromised LV dysfunction. And the management is the same of the heart failure. Digoxin for anti-failure, digoxin diuretics اللي هو البريلود، الافتر لود، الايس انهبيتر اللي هو مرات يقول لك يشتغل على البريلود والافتر لود، ممكن انهم دول افكت، والبيتا بلوكرز اللي هم الكارديو.
يعني هنا ما عندنا سبيسيفيك تريتمنت مثلا انتي فايرال او كورتيكوستيرويد او فد شيء.
ما بعد هو صار دمج وانتهت انتي فايرال، الفايرال illness صار before 2 weeks before 3 weeks، بعد ايش بقى عندك هذا انتهت الامور، صار عندك كاردياك دمج زين، ويبقى انه على الهارت فيلر تريتمنت.
زين دكتور،
بس نقول
عادة هذولا يعني يكونوا ريفيرسبل، يعني بعدين يرجعون لو راح يظلون كرونيك هارت فيلر؟
50% 50% will regain normal ejection fraction, and 50% will end with chronic heart failure. فنقولهم للأهل، هم هذا سؤالهم دائما، هل هو حيرجع؟ زين، نقول لهم يابا 50-50 ما نعرف يعني، فهذا البروجنوسيس مهم، هذا دائما الأهل يسألوك عليه. شايفين هواية إنه 25 و 30 ورجعوا الإنجكشن مالتهم 50 و 55 ووقفنا التريتمنت حتى عنهم، وقسم ظلوا وهذا هو وحظه. واضح؟ حتى هسه الكوفيد 19 هم واحدة من الكومبليكيشن مالتهم هم الكارديوميوباثي والكاردياك فيلر والهارت فيلر، هواية صارت عندهم. زين، هماتنا نفس الحساس. واضح؟
تمام، شكرا دكتور.
اكو احد عنده سؤال؟ لكم سؤال تقدرون تاخذون راحتكم، وحيدر تعطينا من الامتحانات ان شاء الله على الاسبوع الجاي، شو وقت امتحانات بيدياتريك؟ ماشي عيني،
ان شاء الله دكتور.
يلا موفقين ان شاء الله. في ماله.